Okay, so this is the PowerPoint that is discussing the current issue in professional nursing project. Um, this is entitled Harm Reduction in the ER, Applying Evidence-Based Practice to a Vulnerable Population of People Who Use Opioid Drugs. So the community that this is approaching, this project considers people who use opiate medications, both prescription and non-prescription, who live in Jackson County, Oregon, the area where I live and practice as an ER nurse. And it looks at those members of the community who present to my hospital for care that is related to that use. So basically, current opiate users living in Jackson County, Oregon, who come to the ER at Asante Ashland Community Hospital for health concerns that are related in some way to opiate use. This population includes people who permanently live here and are residents of Jackson County, as well as people who are traveling through. Um, I'm going to, come up with more statistics and talk to more community leaders about this in the final project. But anecdotally, I know we see and treat a significant number of homeless folks who, of many of those who live here, and then many as well who are traveling through, who live in other states, who, just come here for the summer, or, are traveling through on the Pacific Crest Trail, or, any number of folks from all sorts of places um, find themselves here and sort of live off the grid and outside of a lot of those social services. Many of those folks are users of opiate medications as well. So we see a lot of those people in the ER, and so that's kind of who I'm looking at here. So consideration of the community includes Jackson County at large. Um, we have to consider this idea of harm reduction because this is a huge part of what I want to make this project about. We need to look at what harm is it that needs to be reduced. So there was an article in the Medford Mail Tribune, our local newspaper, out on April 28th of this year that talked about a spike in opiate overdose deaths in this county. There have been 10 deaths so far in 2018 from opiate overdose, which is a significant increase from last year and the year before that. Our public health department is pretty robust here and supports things like a syringe exchange program. And the director of public health actually just issued a statement calling for IV heroin users to use test kits and check what's in their supply, if it's containing fentanyl or carfentanil or other additives that would potentiate the actions of those opiates and make it a lot more dangerous. So there is some work around this being done, and harm reduction is I definitely see it in play in some of the responses that this county is giving towards this public health problem. So as an ER nurse, I see a significant number of patients with injection-related abscesses. Sometimes these patients will come back again and again and again for the same problem. Oftentimes they end up getting admitted, which drives up costs, especially in this case because a lot of these folks don't have traditional jobs. They might not have they might not have private health insurance. Some of them do have public insurance through Oregon Medicaid, which is facing huge budget shortfalls this year. So any additional strain to that publicly funded program is an issue that we need to deal with. In addition to those problems, we also see a lot of chronic constipation, bowel obstructions related to chronic opiate use, generally in our older crowd, and overdoses as well. So people who use opiate medications come from all walks of life, all different socioeconomic strata. The community of Ashland, Oregon is generally fairly well off. There are a lot of retirees who live there with fairly sizable incomes. A lot of them worked in the San Francisco Bay Area in tech and made a lot of money and moved up here. And a lot of them do use opiate medications. And so we see a lot of those folks come in with, some of those constipation issues that I talked about. These are people with nice houses, good retirement plans. They have a primary care doctor. And we also see a lot of people on the other end of the socioeconomic spectrum as well. Homeless folks, people who are IV drug users. Some of those IV drug users also have nice homes and good jobs. So these folks really just sort of, they come from all over the map. However, for a lot of people in this group, their only access to healthcare treatment is the ER. Not that they couldn't access primary care, but it's just, a lot of that takes planning and transportation and making the appointment and following up with that appointment, whereas ER under federal law, we see everybody every time for a medical screening exam, regardless of ability to pay. So we, in effect, do serve as that sort of primary care home for a lot of folks from this community. So concerns about health, it depends, but a lot of times they seem minimal, can be secondary to the needs for the drug of choice. A lot of times, prescriptions for antibiotics to treat an abscess are just discarded, rarely complied with, but the prescriptions for pain medications always get filled. So that's a disconnect that we need to be looking at here. So in general, like I said, Ashland has a lot of financial resources. It's a community considered to be pretty progressive in terms of folks are generally fairly involved with their healthcare. There's a lot of alternative health clinics, a lot of naturopathic, I would use quotes here, doctors. But people generally are pretty interested in taking charge of their own healthcare. Again, depending where you are at on that socioeconomic scale, it makes it a little easier for you or not. We also have to look at the culture of the hospital. So the hospital that I'm talking about is Ashland Community Hospital. It's a 45-bed small hospital, but it's linked to a much larger hospital system called Asante, and that is one of the largest employers here in Southern Oregon. They run the large flagship hospital that's 15 miles away, and so Asante is the nonprofit that runs Ashland Community Hospital. So we have to look at the overall culture of that hospital system. So looking at the Asante mission statement, it says our mission is to provide quality healthcare services in a compassionate manner valued by the communities we serve. So that's a really important thing to think about, compassion. Oftentimes, provider attitude of people working in the ER can be somewhat less than compassionate in dealing with folks who come in again and again and again for treatment of conditions that are easily preventable, people overdosing again and again and again on the same substances, you know, interventions just not quite working, people not ready to deal with them, or maybe not dealing with them in the way that we would like to see. So it gets frustrating, and there's definitely a lack, I think, of compassionate care there when it comes to this particular group of people in this treatment setting. So issues and questions to consider. There's growing concerns about the risks associated with opiate use, particularly IV use in our community and the United States overall. So the U.S. Department of Health and Human Services declared this public health emergency last year. There is increased cost of hospitalizations directly related to drug use. I want to look at harm reduction. It's really emerged as an evidence-based strategy for reducing risks and costs associated with drug use. And we can definitely implement that into bedside nursing care, particularly in ways that we are supposed to be patient advocates by using evidence-based practices. And ER is a lot of times that primary point of care for high-risk populations. So we can use that space as a really fruitful area of intervening in some of these ways with this community. So the questions I really want to look at: what are the problems associated with opiate use in this target community? What role does the ER play or could play in addressing these problems? What is this theory of harm reduction, and can this be a valuable tool for clinicians and our patients in addressing opiate use? And how might resources or education be similar or different in addressing different types of use? So a little bit of background: how has this been dealt with in the past, and what do we need to do? So Jackson County Public Health has a syringe exchange program. They have a pretty bare bones training, not really a training program, but they talk about safe use, bloodborne pathogen testing available all at no cost. Last year in the legislative session, Oregon law changed to allow pharmacists to prescribe and dispense naloxone to the public on demand. ER also has handouts on drug treatment programs, but they don't have a lot of discussion. Some of them are pretty out of date, and other nurses that I've talked to are not aware of the syringe exchange program. And so there's a huge opportunity that's being missed to provide some of that preventative care that's based in actual research. And then something that I'm going to be talking to my boss about is, so we used to do some screening and triage as far as like alcohol and drug use at home and how often, and using that as part of an algorithm to spur further interventions later on. That's not a part of our triage assessment anymore in the latest EPIC upgrade. So I'm not sure why that is, but that's something I'm going to be asking to talk to the manager about as part of this approach. Um, the other thing is, so the opiate problem has been declared a public health emergency, but it doesn't appear that we've really been given any more resources to battle the problem. And so part of my question is, how can we help lead the way and advocate for the safety of this vulnerable group and not just target them as a problem? So social impact, as I mentioned earlier, there's been an increase in opiate-related deaths in this county this year. Healthcare costs are rising. There's not enough money to pay for it, or at least money isn't being appropriated in the ways that some of us think it should to pay for this problem. Um, as far as other interested parties, I plan to talk to Dr. Shames, who's the head of the Jackson County Public Health Department, to discuss things like heroin testing kits, how those might be made available in the ER, or how we can easily direct people to access those. And then I want to talk to hospital administrators as well, one about the triage questions that are missing, and then whether we can look at the number of admissions related to IV abscesses and opiate use more generally. And then talking to the department manager about implementing new discharge education. So again, services currently available. I've touched on this already. There's a syringe exchange program. It's open to everybody. They only give out the number of new needles that they receive and used needles. And they describe this as a level of tertiary prevention. Um, and the other question is, can we help connect people with pain management doctors as well? And like sort of trying to look at some of those other modalities of pain treatment. And then again, just touching on that issue of getting a hold of Dr. Shames in the Department of Health and how we connect patients with the heroin testing kits. So strengths. The hospital is dedicated to providing egalitarian, respectful care. It's evidence-based, and that is enshrined in their mission statement. So another strength is the ER sees all patients regardless of ability to pay through federal law called EMTALA. So that really puts us in a very unique position to assess and intervene and provide some of that preventative care that other settings really can't do. It's a really good opportunity. That's how I see it, as a really good opportunity, even though sometimes it's very frustrating and we're stressed and we're overworked and we just want to, get people in and get them out. That's a real opportunity to affect preventative care and improve a person's health and strengthen the healthcare system as well. The other strength is the patients themselves. They will interact. They will ask and answer questions about teaching and prevention if they're approached in a non-judgmental manner. So that is a biggie. There was a standardized tool called the Addiction Talking Points that I found in my research that I'm just going to briefly touch on here. This is sort of a flow sheet to guide you in talking to someone who you think might be dealing with opiate use disorder. So moving on to analyzing weaknesses, I think that nurses need to be better supported in this regard. There's also, again, that stigma about drug use that can result in less compassionate care. And what we need to do is implement a prevention framework that provides support, clear direction for the nurses, more education, and just framing it in a way that, that we're talking more about prevention and reducing the overall workload, right? Patients can be reluctant to disclose their use. So that's another big roadblock and weakness because they fear legal intervention or substandard care. We can approach this by, reminding them that all services are confidential, but also making them aware of our status as mandatory reporters in certain situations. So, people need to be aware of that as well prior to disclosure. So cost of improvement, many of the costs are already borne by the community. The public health department runs those programs I've talked about. The hospital shoulders much of the burden for treating those preventable illnesses and wounds related to use. Could be a slight materials cost in terms of creating a handout or better discharge instructions, but there's already a multitude of old, outdated handouts, and so this could save money by streamlining and condensing and updating the information. So recommendations. I recommend that the ER at the Asante Ashland Community Hospital develop a standardized approach to treating opiate-related medical conditions that is based in harm reduction and tertiary prevention. So to do this, we're going to use current evidence, input from community leaders, and draw on existing social services. We want to make sure that ER nurses are armed with best practice information in the form of an easy-to-read, current, and non-judgmental resource packet discussed with patients. So, a couple pages of references.